My name is Dr. Anne Cruikshank, and this presentation is looking at the complexity of Lyme disease and how it may present in primary care. Lyme disease is an infectious disease caused by the bacteria Borrelia burgdorferi, which is a spirochete. It's transmitted by the bite of an infected tick and is the most common tick-borne disease in Europe and North America. Borrelia burgdorferi has multiple genus species, and this is felt to be the reason for the different presentations, with Lyme arthritis being more common in the USA, whereas neurological and skin presentations are more common in Europe and Asia. We do know that the bacteria can spread quickly around the body, is attracted to a range of tissues, and can hide from and disrupt the immune system. The symptoms of Lyme disease have been recognised in mainland Europe for over 100 years, but the cause was unclear. And the name comes from the town of Old Lyme in Connecticut, USA, where in 1975 a cluster of children were diagnosed with juvenile rheumatoid arthritis. But this was subsequently found to be caused by a tick-borne infection and subsequently named Lyme disease. It was first reported in England and Wales in the 1980s, and in 1988 was described as the new great imitator. This was a comparison with syphilis, another spirochete, which can mimic many other diseases. The incidence and seroprevalence across the world is unclear due to the lack of any standardized data collection methods. In the USA, there are thought to be almost 500,000 cases a year, France around 50,000 cases, Germany about the same. In the UK, there's been an estimate of around up to 2,000 to 3,000 cases per year. However, only laboratory confirmed figures are recorded in the UK, and the number of cases being diagnosed clinically has not been reported. What they've now realised, looking at some blood donor work, has shown that there's a seroprevalence in blood donors in the UK of about 0.49%. So that's about 1 in 200. So that's hundreds of thousands of adults. So they're now doing some CPRD work to look at because many cases are just being diagnosed in primary care without needing to be tested. So ticks are tiny. They're found in rural and urban areas, and they're carried on birds, small mammals, as well as deer. So you don't have to have deer charging through your garden or the park for there to be ticks around. They may even get carried into the house on your dog or cat. So Big Tick Project back in 2015 showed, this was looking at ticks taken off dogs by vets, showing a high incidence in the south, in Norfolk, in Scotland. The map from UKHSA is just ticks that have been sent in. So areas that are blank, there were still going to be ticks there. They just maybe haven't been sent in or picked up in that area yet. So the nymphs are tiny. The size of a poppy seed, so you're not actually going to see them often. Some of you have maybe been over to our stand at the Lyme Resource Centre and actually seen how tiny they are. And they inject local anaesthetics, so you don't know you've been bitten. And they, on average, about 5% are infected, but it can be higher in some areas. And they're also carrying other infections. There's actually been tick-borne encephalitis in a couple of cases in the UK now. So there's a focus on various different European infections that are also coming in on different ticks. Children tend to be bitten above the waist, so always check around the hairline, behind the ears, around the neck, this sort of thing. They attach, if they can, in sort of moist folds in the skin and may just stay there. You won't even notice. They don't necessarily get huge like that large tick there. They may just stay tiny. There's no proven minimum time needed for the infection to be transferred to the host, but the longer the tick is attached, the increased risk. And if you traumatize it, removing it, it may well regurgitate into the skin. But remember, the one tick that you saw or removed may not have been the only one, so there may be more ticks to check. And we focus a lot with the charity on tick bite prevention. So suggesting people, even in summer when it's hot, that they're covered up, long sleeves, long trousers, insect repellent, carrying tick removal tools. Again, if you want to come over to our stand, we've actually got free tick removers to give out that were provided by one of the tick twister company. Remember to check for ticks and check children as well as your pets. And what we want the general public to do is to know the symptoms of Lyme so that they will turn up. We did an online survey early last year of patients who'd been diagnosed with Lyme disease, and more than half had no idea ahead of time they should have been taking the precautions or to know what to look out for. And many didn't even know they'd been bitten. So removing a tick, there are different ways of doing this. Tick twisters or tick cards. Again, we can show you if you wanted to visit the stand. But don't traumatize the tick. Don't squash it with big, thick tick removers, sorry. Don't cover it in oil or burn them with cigarettes. Anything like that is not a good idea. And patients may come in with ticks attached. Have you got something in your practice in order to be able to remove them? I'm hoping this now works. Just to show you how you do it. They actually are more difficult than you might think to remove sometimes. And these are the twisters that we have to give away for free. So, Lyme disease, different stages. Again, like syphilis has different stages. So early localized, early disseminated, late disseminated. And then there's the issue of persistent symptoms. What that means is symptoms after standard treatment. And this is what sometimes is called post-treatment Lyme disease or chronic Lyme. What people don't know is, in how many cases is this ongoing infection? How many times is it just inflammation? Is it a combination of all? But this idea that chronic Lyme disease doesn't exist is not true. Some kind of chronic persistent symptoms can exist in 10 to 20% of cases. So early on it's pretty easy. If you see this erythema migrans rash, you'll know exactly what to do. Ask patients if they phone in to take a photo in case it's changed by the time they get seen. You may be associated with flu-like symptoms, but not sore throat, sore colds, just aching, neck ache, headache. It might be severe, it might be mild. But what tends to happen is people don't remember the tick bite. The rash is atypical. They're assumed to have a virus, and no one's thinking about Lyme. So the erythema migrans usually occurs 3 to 30 days after the bite, but might be longer. But absent in 30%, who may only just get viral symptoms or not much at all, it tends to not necessarily be a bullseye. And it's usually painless, not hot, not itchy, and that's how you might be able to distinguish it from other insect bites. Patients say they've got an insect bite, but when you ask them, they don't remember being bitten. It's not hot, it's not painful, it's not red, it's just there. And they're the times when you need to be thinking about this. Take a really detailed history, and that can actually sometimes take quite a while just to get clear as to what may or may not have been happening. Remember that many of these people might be going to, rather than getting to the GP, they're probably getting to the practice nurse or the pharmacist, or ending up in A&E. And you treat an EM rash without testing based on NICE guidelines. So these are a couple of the rashes that are seen on the NICE guideline. This is how alternatives that can happen. You can get multiple rashes as things start to spread. The rash in the top corner over that side was actually a patient presented to a pharmacist who thought it couldn't be an EM rash because it wasn't a full circle. Fortunately, she did go back to the GP and get treated. Now, I'd be interested to know what you think of this. I'm not quite sure how that's slide in at the top middle to end up in this list, but can you just see on the eyelashes there's a tiny tick just attached in the middle of the eyelashes. I think this was a child. It shows how difficult they can be to see. So, interestingly, I'd like to know how many of you think these may or may not be erythema migrans. Maybe you're happy to put your hand up. A, do you think that's an erythema migrans? C, D, E, F. Yeah. So you're quite right. Actually, the first one isn't a erythema migrans. It was actually a small little abscess that developed some redness around it. All the others actually are erythema migrans. But you can see how a photo of that of D, if someone was complete, it could easily have been a really nasty infection if they had a lot of pain or swelling. The slide E was actually a doctor, senior doctor, with 4 medical colleagues who between them just could not work out what this was. It was completely painless, just appeared. Thought maybe it was an allergy to a rash. Didn't at all want to be convinced it was an erythema migrans. But you can look, if you can see that there is a central area and then a spreading redness. He was treated, he didn't want doxycycline, he was treated with amoxicillin for 3 weeks. Rash went away and a week later it came back again. So he had another 3 weeks and after that was cleared. So you do need to follow up as to what happens even after the first treatment. If you're looking at it on pigmented skin, it's really even more difficult to diagnose. Borrelia lymphocytoma is another symptom that can occur in Lyme disease, often probably difficult to distinguish, but hopefully the dermatologist would recognize that. Again, there you've got erythema migrans, the lymphocytoma, and also acrodermatitis chronica atropicans. That's a really late symptom of late Lyme that hasn't been treated. So in the early stages, you probably get the cardiovascular and neurological symptoms. Facial palsy, whenever you see facial palsy, think about the possibility it could be Lyme, and you may or may not be able to exclude Lyme. You may have to think about including antibiotics. Patients often say they're anxious, but they don't know why. They're getting sudden neuropathic pain. Sometimes the symptoms are associated with the site of the bite. A bite on the leg, and they've suddenly got all this neuropathic pain going down the leg, or in the neck it's going down the arm. You can also end up being with a Lyme meningitis, which could easily be missed. A couple of doses of antibiotics, they seem to be better. LP was negative. It's assumed to be viral, but what you've actually got is a partially treated bacterial Lyme meningitis. And then it gets complicated when it disseminates through the body. Neurological, cardiovascular, MSK, fatigue, even eye problems. Many people may not be aware of that. Neuropathic type problems, just a whole range. And that's getting confusing because you're the one seeing a patient who used to be well. The individual consultants might only be seeing one feature of this, but you're seeing the whole thing, and it might be years down the line. The patient may not even know they ever got bitten. Pediatric Lyme can be difficult because the children can't always explain. They just may be tired, they've got headaches, they're just not happy. But facial palsy in children should be assumed to be Lyme disease, really. The conclusion was if you're in endemic areas, but of course children can travel around the country. It also says until proven otherwise. If this is early Lyme, and facial palsy can occur in early or late Lyme, if this is early Lyme, the test could be negative, so you're not going to be able to exclude it. And this is where we get to this idea of the new great imitator. And I have come across a colleague in the USA diagnosed with motor neuron disease, quite severe motor neuron disease, wheelchair-bound. 4 consultants decided it was MND. It actually turned out to be Lyme disease. He was treated with prolonged IV antibiotics and recovered to about 70% of normal and lived for another 20 years. So it can easily be mistaken for other conditions. You need to think about that. Cardiac symptoms, a pericarditis, a myocarditis, if it's not getting better, may not be viral. It could well be Lyme. It's sometimes functional neurological disorder. It's not uncommon patients to get that diagnosis, often not even having had a Lyme test. And this, on our survey, was the kind of diagnosis that people were getting prior to being diagnosed with Lyme disease. And might have been years down the line before they got diagnosed. And of course, all these symptoms overlap. And of course, everyone with chronic fatigue doesn't have Lyme disease. But the problem is it's difficult to exclude. You may be able to confirm Lyme, but you can't always exclude it. So testing is where it gets complicated. As I said before, EM rash, you don't test, but you use the test as part of your diagnostic tool, not to exclude it completely. and the NICE guideline says you can't exclude it on a negative test. There's no test of cure. So how do you feel when someone comes in and asks for a Lyme disease test? Maybe a bit uncertain or uncomfortable or a bit irritated because this is the fourth person today who's come in to ask you if they've got Lyme disease, and you're not quite sure what to do. On the other hand, you don't want to miss the ones that, could well be a very late diagnosis. And this is a comparison just to explain why this is complicated. In syphilis, where there is no controversy of any kind, the test is accurate, there's a cure, and there's an evidence-based treatment. Lyme disease, it's variable, especially in the early stages, and in the late stages where someone might be severely ill and immunosuppressed, again, they may not have a positive test. You can't test for cure, and there's very little evidence base to the treatment programs that there are, and that treatment varies across guidelines across the world. And then again, if someone has a positive syphilis test and no symptoms, they get treatment. But it seems to be that people think if you had a positive Lyme disease test but you're apparently well, you don't need treatment, and we don't have evidence either way on that. So the key points with the testing, what you're doing is you're asking for Borrelia, and you're sending it to the local lab who will do an ELISA. If that's positive or equivocal, they'll send it on to Porton Down or to Regmore in Inverness, and they'll do an immunoblock, but it takes a while. They can also look for co-infections if you're concerned about where else patients might have been, and you can speak to them. And the test that comes back often says treat based on clinical suspicion. And then people get panicked about, well, was I really suspicious or not? But if you had a reason to send the test off and you've got good reason to treat, then start that without waiting for the result. Porton Down would also like, if you can, for you to download their form and put it in with your ICE form. Give as much clinical information as possible, because that helps with the analysis. And you can find that just by searching on Lyme disease test form and put it in with that. If a patient's been sick for more than 12 weeks, you should actually specifically say, please, sick for more than 12 weeks, please please do a Lyme blot, whatever the result of the ELISA, as per NICE guideline. And this is what might come back. This here, with all the banding, is what Porton Down will send out to the local lab. And sometimes you'll get that directly, and it may or may not make sense to you. Sometimes the local lab will summarize that as a positive or a negative. In this particular case, IgM was negative, IgG was positive. This was a child who'd been unwell for quite a long time. For some reason, the consultant then felt that suggested old past infection, but this is a bacteria, hasn't been treated already, so should be treated. Treatment was refused. Child got sicker and sicker. The next test showed even stronger. These are two different patients, by the way, but the next test on that child showed that the immunoglobulin bands were increasing in intensity. He had treatment, but he still never got better. So it is important. Again, it says treat based on clinical suspicion. So treat if there's a reason you think this might be Lyme. So the guideline says, as we've just said, treat with an EM rash, don't bother testing. Sometimes if you're unsure, you may want to test, but you don't use it to exclude the diagnosis. And do treat and assume Lyme if you have clinical suspicion. This issue of doing another test 4 weeks later, again, if somebody's unwell, do you really want that infection to keep spreading around the body? So I'd start treatment. Treatment-wise, the earlier the antibiotics, the better. Probably even 2 months down the line, it's getting harder to treat people. Dosages are higher and longer than normal, than other conditions. And you need to give, if after the first 3-week course they're no better, give 3 weeks of another antibiotic. There may be no indication for prophylactic treatment, but think about cases, maybe if a patient was about to start immunotherapy, already immunocompromised, start to have chemotherapy, something like that, you may want to treat them just to avoid that risk that if they've been bitten and they're about to start treatment, that there's no risk. But you could discuss that with their carers. There is a potential for pregnant women to transmit the baby. We haven't really proven any cases in this country, but it is potential. So basically, rash is diagnostic. You can treat based on clinical suspicion. And the evidence for these guidelines is limited, and the committee admit that, and they recommend more research. And there's no international consensus. So this is standard treatment. It's in the CKS guideline. It's in the NICE guideline. Children from 9 and above should be on doxycycline. The reason to use doxy is it covers more of the tick-borne infections, just in case there's more than Lyme. Very high doses there that you can see. Think about the Herxheimer reaction, where you may get a flare of symptoms as you kill off bacteria. And if they've got cardiac or neurological symptoms, they'll probably be at the hospital anyway and may need IV. This is a really good visual guide from the BMJ. We've got some booklets on our stand that we're giving out that have got all of these links in them. And you're welcome to come and get those, or take the QR codes from the website over there. Persistent symptoms. People like Johns Hopkins are looking at this. They're acknowledging this is persistent symptoms after standard treatment, and they're really not quite sure what the cause is, when it might be infection, maybe anything else. And this is the kind of pattern of symptoms. Fatigue is one of the biggest. And we did our own research on, as I mentioned, on the trial. And if you look at our patients and Johns Hopkins, we're finding exactly the same thing, that fatigue is one of the biggest ongoing symptoms. But of course, if you look at all these, they also fit with chronic fatigue and lots of other conditions. But that's where the overlap is, also long COVID, and we're just not clear what's going on. The suggestion is that further treatment doesn't work. The trials were last done about 20 years ago, and actually there's a lot of uncertainty over that. There are plenty of doctors outside the UK who are treating for longer courses of treatment, and plenty of patients who get better that way, but nobody's doing any trials to look at that. So key points is complex, don't rely on the testing, and your early treatment gives you the best option, and really listen to your patient. So I think your role is raising awareness. We've got posters you can put up for the patients to be aware. Early diagnosis, early treatment, accurate read coding, because that's going to be the only way we get an idea of the incidence. Think about late Lyme in your complex patients, and support your patients. Lyme disease toolkit, lots of people don't seem to know about that. We've been doing a survey. It's a real way to just quickly look stuff up very quickly if you're in surgery, or if you want to direct your patient to patient support groups, this sort of thing. The booklet is what we've got over on the stand. There's NICE and there's CKS. And let's just develop a Lyme-aware practice, because patients are going to see lots and lots of different people within the practice, and it'd be better if you were all on the same wavelength here. There's the toolkit, there's the booklet, there's an e-learning module, also with RCGP. Think about whether to do a practice audit and just how many patients might have Lyme in your practice that you're missing. As I said, 1 in 200 of the population, that was just based on blood donors. So Lyme disease awareness is in May. We've got lots of posters, leaflets we're happy to give you. The other thing to think about is your own personal safety and your children. A lot of people have been taking leaflets to go back to their schools and say, can you make sure the kids are all being protected? Does someone know how to take off ticks if they're on a school trip? And if you look on the LRC website, then we have got a lot of information for schools, for outdoor organisations, Duke of Edinburgh, as well as just thinking about your medical responsibility. But that's it. Thank you.
Thank you very much, Anne. We've got a couple of questions in a few minutes. So the ones I've got online have come in so far. First one is, given the guidelines are not to treat a tick bite until there's an EM rash present, do you think this needs reviewing if 30% of cases don't have a rash?
I don't think it says don't treat unless there's a rash. It says definitely do treat if you see a rash. And it says if you don't see a rash, think about testing, but treat based on clinical suspicion. So you don't need to wait for a rash. Yeah.
One that's just popped up the list. Once patients have completed a course of treatment, we usually say they have been treated. You mentioned a second course of treatment. When should we consider this, especially as something that might be different?
Okay, the guideline actually says, NICE guideline says, if they're no better at 3 weeks, either they've still got the rash or they've got other symptoms, then you give 3 weeks of a different antibiotic. So I would plan to see them at the end of that course. Don't stop and wait and see what happens because it's a slow dividing organism, so you may not have killed it all off yet. So, and if they seem to be better, and as I mentioned with a friend who then had another rash, that they may come back then. But if at the end of 3 weeks tell them they need to be seen. Don't end up that they can't get an appointment. That's the only other thing, is it, you don't want to delay that they're still ill and can't get back to you.
And then the next one's a bit more complicated. You mentioned to raise awareness with posters and encourage education to patients, but late tests don't appear to add to diagnosis, and late treatment doesn't seem to improve symptoms. Are we risking a diagnosis that we can't do much about, heightening patient anxiety and fear?
Okay, so one of the things about raising awareness is the poster. If a patient knows that this vague rash on their leg could be Lyme disease, they feel perfectly well, why bother bothering the doctor or trying to get an appointment or fighting with the receptionist to get through? That's where we're talking about awareness, is those early stages, definitely, where people will come and be seen. The later stages, we have to accept that we are missing patients. Some people even later on will get a positive diagnosis, but yeah, you are going to get a lot of people who think they might have Lyme and you've got no way of proving that they haven't. It's a difficult balance.
And nearly on with the treatment, if we do the primary care bit, when patients first present, are there specialist centres around the country where they're more in tune with how to treat Lyme? Because I know I've had challenges when I've rung up ID consultants.
So the NICE guideline was sort of set up to standardise treatment, really. Nobody's doing any research, but I certainly know of plenty of patients who have gone outside of the NHS. Now, you've got to be very careful in that situation as to who they're seeing. I'm sure some people are treating, but there are people who will get better with longer treatment. And personally, maybe in the past where I've used a combination, maybe 2 antibiotics together, if they really know better and we know it was Lyme, why stop if they're still ill? Some consultants might do that, but there are no specialist clinics.
And so our best route is through to infectious disease.
There are no infectious diseases clinics. They will still say, well, I can't go. Many of them will say, I can't go outside the guideline, which is difficult.
And then I think finally, a very practical question. If you have a go at removing a tick, and I've had one, I know how hard it is to get rid of them, what happens if it goes wrong? What do we do then? If you think that you've taken off part of it and it may have then just regurgitated into you?
Well, only 5% of ticks are infected, so you're probably okay from that point of view. People worry about this thing, well, if the head's stuck in, does that really matter? What should I do? Do I dig it out? It's just like a foreign body at that point. The trauma's already been caused. If it was infected, it may well have gurgitated into you, but again, you wouldn't always treat. But I think if you had other people who were sick with other conditions, and you really didn't want any risk, and sometimes people are quite desperate, they've had a family member really ill, I think there are some GPs who say, well, look, on balance, I'll treat. We're talking about doxycycline. People can buy it online for going on as an anti-malarial. They're using it for acne. And sometimes you've just got to weigh up the balance of where
Given that it's only 5% infected, are there areas of the country where we can be reassured when someone comes in with a tick and to reassure the patients?
Well, not really. The average is probably 5%, but it can be up to about 10, 11% or more. Not really. I think the important thing is that you feel confident if you've taken a tick off, they've come to tell you they've got a tick bite and don't know what to do and they're panicked, that you're confident on to tell them what to do and when to come back, what to look out for, which might just be the flu-y symptoms. In the middle of summer, if someone's flu-y and maybe they're a gardener or a farmer or they've been out on Duke of Edinburgh, I'd be treating them because you probably can't exclude it.
So I think that brings us to the end before the next session starts. So thank you very much, Anne, and enjoy the rest of the afternoon.
Thank you very much.